البشريه اليوم دوت، وان شاء الله يكون في كمان اكتيفيتيز بره ان شاء الله. يعني نتمنى ان الليكتشرز والمحاضرات بتاعت اليوم النهارده تكون مفيده بالنسبه للجميع. برحب بالزملاء الموجودين في القاعه، وبرحب بالزملاء
بعدين البرزنتيشن بيشوفوا ولا لا؟
وأقدم الدكتور ياسر نوري رئيس القسم ورئيس الفاعلين. بسم الله الرحمن الرحيم. سيدنا محمد صلى الله عليه وسلم. في البداية السادة أرحب بكم في حضور الفعالية.
انا بقول لك لا حاجه رهيبه حاجه رهيبه. لا 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 يعني يا عم استنى هطلع والله هطلع.
انك انت عرفت من نايسي.
ايوه لا انا هورينا عرفت القصه كلها. وانت انا اصلا هقول له في وشه، هقول له انت دلوقتي انت بتتحامل على شخص تاني وانت الشخص الثاني. هقول له كده بس انا عملت كده فيصل. اصلا انا ما بحبش الاستفزاز. يعني ايه اللي هو يعني احنا امبارح بنتكلم في حته ان انت يا ابن الذين. اقول له قلت فيصل، قلت له يعني هي دي غلطه الثاني ليه
ايوه السلام عليكم.
Ready?
محاضرات الدي ان ايه
بدأت.
نيوتن.
Yes, my dear. Oh, yes, yes, you want to clean everything. All right. It's not a problem.
بس ما ينفع تسوي
دي اللي هي بتاع السيفتي، مدينة الملك عبد الله. ماشي.
بس مش عاوز حاجة. فين يا عم الصوت يا عم؟ الراديو جاب ميوت.
أيام
دكتور قفل حقك، جربوا دحين. هم كهوس.
احنا سامعين صوتكم، انتبهوا بس صوتكم واضح لنا.
شكرا، ما أدري الصراحة. جربوا.
طيب we will continue talking about
أيوة كده.
اوكي يلا. that are provided by foreign service providers. طبعا لأنه كانت في بعض المشاكل فيما يخص
خلاص كملي كده. أي.
In terms of virtual events,
شكرا.
مثل بدأ تعمل مؤتمرات عن طريق شو اسمه الاونلاين. طبعا يتبادلوا الخبرات حول العالم. provide a forum with the exchange of information among the states. بيعملوا تناقل الخبرات فيما حدث خلال فترة كورونا. طيب exposure in medical facilities عندنا it was noted that personal important for safety are available in the facility. مثل مين؟ radiation protection officers, radiologists, medical physicists, medical technicians. هناخذ الآن بسيط عن بعض الخبرات اللي أو الأشياء اللي حصلت خلال هذه الفترة. طيب في مجال الإكس راي طبعاً في عملنا فيما يخص الجدول تم التقسيم بمعدل 50%. تم توزيع الجداول 5 أيام عمل و5 أيام أوف. تم عمل حالات في حالة الاتصال فقط للموظف. كان التوزيع إنه موظف واحد مرة واحدة في الشيفت بيعمل حالات كوفيد. فيما يخص الصحة النفسية للموظفين طبعاً في بداية المرحلة كان موجود تخوف كبير، لكن بعد مرور الشهر بدأ التخوف يقل طبعاً بحسب ما تواصلت مع الأستاذ نبيل مشكورة الله يعطيه العافية إنه كان في جلسات مع استشاريين نفسيين. طبعا كانت المرحلة الصعبة هي فيما يخص التعقيم، كان الموضوع معقد ولم تعرف الطريقة المثلى للتعقيم، كانت توجد معاناة مع مكافحة العدوى بسبب عدم وضوح آلية انتقال العدوى، لكن بعد ذلك أصبح التعقيم لكل جهة بعد كل فحص. فيما يخص الأجهزة وجد الكثير من الأعطال بسبب التعقيم المكثف وطريقة التعقيم الخاطئة للأجهزة، ولكن تم تدارك الوضع بعد عدة تجارب حتى بدأت يتم التعقيم بشكل صحيح. تم سحب عدد 2 من أجهزة الأشعة تعمل تحديث وتعقيم أجهزة المجمع. طبعا هذه بعض من الأشياء اللي صارت خلال الفترة كوفيد 19 وكانوا يمروا بها بعض الموظفين. فيما يخص الأشعة المقطعية طبعا بداية شهر مارس 3 مارس كانت أول حالات كورونا. كان الجميع متأهب وفي قلق من الدخول على الحالة من أطباء وتمريض فني أشعة. أول حالة الكورونا كانت لطبيب مقيم، تم طلب عمل أشعة مقطعية للصدر وكان الجميع في قلق وخوف من عمل الحالة في ذلك الوقت. بعد ذلك تم تخصيص غرفة أشعة خاصة لحالات كورونا وتم التواصل مع موردة المريض لتجهيز الحالة وتم تجهيز غرفة الأشعة. طبعا المشرف وليد الله يعطيه العافيه كان اتمم استعداد لاستقبال الحاله من لبس وتغطيه جميع المناطق، يعني التزم بالبروكوشن. تم تغطيه جميع الاغراض الموجوده في غرفه الاشعه، كان في حلق، تم وصول المريض وعمل الحاله في اقل من 3 دقائق. اقل من في العمل العادي بيتوفر الحاله تاخذ تقريبا 3 دقائق، لكن مع مرضى كورونا بدأت الحالات تاخذ من حوالي ساعة ونص بسبب مثلا التحضيرات والتجهيزات للغرفة. طيب بالنسبة لقسم الفيزياء الطبية أستاذة رنا قالت إنه لم يتوقف عمل الفيزيائيين، كانوا بيعملوا معظم الاختبارات. كان رئيس قسم الفيزياء الطبية بيستخدم فرصة التعقيم للغرف لإتمام كافة الاختبارات. فيما يخص الحماية من الأشعة أستاذة غادة الله يديها العافية برضه أعطتنا معلومات إن هي كانت تشتغل ديك الفترة بقسم الأشعة. كانت بعد كده انضمت لرئيس قسم الحماية ولكن لم يتم تنفيذ بطاقات قياس الجرعات الشخصية مما أدى إلى وجود عدد كبير مفقود. بعد كده تم عمل استبدال جزئي، بعض الموظفين راحوا يعملوا بالتخصص الوبائي، يعني كان في أشياء مختلفة في تلك الفترة. بالنسبة للموجات الصوتية برضه تم تقسيم الجداول بنسبة 50%، تم التعامل مع الحالات مثل حالات الايربورت لكن أضافوا الفيس شيلد، تم اختصار مدة الفحص. ليش؟ طبعا لأنه في كلوز كونتاكت مع البيشنت. في الالتراساوند المريض تقريبا كان ياخذ 10 دقائق بس اختلف يعني عن باقي الأجهزة. تم استخدام البريكوشنز، تم استخدام precautions ويتم ترك الجهاز في غرفة الفحص لمدة 2 ساعات. طيب بالنسبة للإم آر آي أستاذة إلهام قالت لنا كان العمل صعب خلال فترة جائحة كورونا لأن المرض كان مشهور، كان الرعب يتملك الموظفين، يوميا يتم قبول حالات للكوفيد 19 برغم المعرفة المسبقة للعديد من المنشآت ما بتعمل حالات إم آر آي إلا بعد أن تصبح كلير. كانت المشكلة الأساسية في تلك الفترة قلة عدد الأخصائيين بحيث تقسيم العمل وعمل حالات كوفيد 19 بشكل يومي. طيب يديهم العافية كلهم. نشوف حاليا بالنسبة لعدد الحالات في قسم الأشعة قبل مرحلة كوفيد 19 كانت الأعداد ما شاء الله تبارك الله يعني أعداد يعني كبيرة جدا. في الإكس راي 62000، في الألتراساوند 8000، 15000 حالة في السي تي، 7000 في الإم آر آي، الانترفنشنال 94 حالة. لكن في فترة إعادة التشغيل التدريجي بنسبة 25% بعد جائحة كورونا بدأت الأعداد كانت تقل، 7000 إكس راي، 195 ألتراساوند، 708 سي تي، 82 إم آر آي. أما بعد المرحلة وبعد رفع القيود بدأت الحالات ترجع لنصابها الطبيعي، 48000 إكس راي، 10000 ألتراساوند، 19000 سي تي، 8000 إم آر آي، 301. نيجي نشوف هنا في الرسم البياني يوضح لنا كيف كانت عدد الحالات قبل مرحلة كوفيد وفي فترة التشغيل بنسبة 25% وعدد الحالات بعد رفع معظم القيود الاحترازية. نلاحظ إنه حالياً بادئ الوضع يرجع شوية مقارنة بالطبيعة بالنسبة للون الأورنج. طيب إيش دور الهيئة الأورجنايزيشن؟ بالنسبة لهيئة العامة للغذاء والدواء بدأت تعمل دورات مكثفة أونلاين بحيث بيعلموا عن الديزاستر بلان، بيتكلموا عن الريكويرمنتس الخاصة لأقسام الأشعة، الاي عملت كونفرنس بشكل عن بعد، وكانت تعمل تجهيزات بحيث انه الموظفين في المجال الاشعاعي يتاهبوا لاي حالات طارئه. هيئه الرقابه النوويه كان عندها شويه تاخير في تغيير الهيكل وموقع معين. الى الان حتى احنا ما احنا قاعدين نعمل تراخيص جديده، في تاخير في بعض الاليات. يعني تاثرت المنظمات بجائحه كورونا بشكل كبير. بالنسبه للحملات التفتيشيه لم يتم عمل الحملات التفتيشيه ولم يتم عمل جولات. ليش؟ لانه almost all of radiation protection programs did not implement their inspection. العديد من فرق الحمايه ما كانوا بيعملوها significant facilities، ما قدروا يزوروا بعض المنظمات. inspector could not enter the facilities. عدم وجود تصاريح لدخول بعض المنشآت الطبيه. القرارات الحكوميه بالحجر ورفع القيود وحظر. the need of secure communication system. بعد كده بدأ يشوفوا طريقة بحيث إنه يعملوا نظام دول اللي عملت استفتاء منظمة هيئة الرقابة National Atomic Energy Agency. عملت قسم بياني يوضح عدد الدول اللي تم فيها إجراءات التفتيش على المنظمات الإشعاعية اللي تستخدم الإشعاع. لقوا إنه عدد الدول اللي لم يتم فيها أي عملية 98، بينما اللي جرى فيها التفتيش 12، يعني تأثرت بسبب الجائحة بشكل كبير. طيب إيش دور الإمرجنسي بلان بالنسبة للحماية من الإشعاع؟ تقريبا كاترين فوق قالت إنه people working where there is a risk of radiological contamination شبهت بعض المشاكل الإشعاعية بمشكلة كوفيد-19 لأنها حاجة إحنا ما بنشوفها لكن مشاكلها كبيرة بتنتشر بين الناس أو بيتأثروا فيها. طيب إيش نتعلم من فترة كوفيد؟ إنه regularity bodies, health authorities and professional bodies need medical exposure. يحتاجوا يعرفوا بعض التعرضات ويكون لهم دليل في حالة الإمرجنسي يستندوا عليه. Regularity bodies need to be prepared to organize their activities. لازم يتعامل بطريقة منظمة لتقسيم الإكويبمنت والإكس-راي داخل المستشفيات. Regularity bodies need to be prepared to address the limited financial resources. طبعا ممكن في مشاكل مالية حدثت في تلك الفترة اقتصادية، لازم نكون متجهزين. Governments need to ensure availability of important radiation safety technical service. بعض الخدمات التقنية اللي هي مثل فحوص الأجهزة، مراقبة التسرب الإشعاعي وغيرها. طبعا في الأخير شكرا لأبطال الصحة، يعطيكم العافية.
Next topic will be the chest X-ray findings monitoring the COVID-19 disease course and severity. Corona is a single complex. It's all posted on
Good morning, everyone. I'd like to thank the organization. It's part of my department and International Day. So I'm talking today about one of the most important modalities. We are using it in our daily practice. It's just X-ray. As you know, we are using it in patient monitoring, the baseline, and then in the follow-up. So today I'm going to talk about the chest X-ray findings, monitoring COVID-19 disease course and severity. At the same of lungs to talk about some findings, and go through some coronavirus-related respiratory illness usually manifests clinically as the morning, with predominant findings of
ارفع صوتك شوي.
radiograph is very helpful to determine the COVID-19 disease course and severity using chest X-ray scoring system, and correlate this with patient demographics as age, sex, and outcome. The American College of Radiology recommends portable chest X-ray as first line for triage. So what we usually find on chest radiograph is consolidation, the consolidation opacity, regular interstitial thickening, ground glass opacity, the hazy opacity, pulmonary nodules, pleural effusion. Most of the patients showed bilateral lung affection with peripheral distribution and lower zone affection. The total severity score is used in baseline and in follow-up of chest radiograph, and we'll talk about it later. So it is proposed first by Warren et al. The total severity score is used to calculate the finding by summing both of the lung scores. As you see here, we are dividing the lung into two halves. So each lung was given a score from 0 to 4, depending on the extent of lung involvement, like consolidation or ground glass opacity. So score of 0 means there's no involvement. 1 is equal or less than 25%. 4 is 75% or more of the lung is affected. 0 to 2 is mild. 3 to 4 is moderate, and 6 to 8 considered severe. Another score is called Brixia score. It is proposed by Puglisi. And this is by dividing the lungs into 6 zones on the frontal projection. As you see here, we are dividing each lung into 3 zones. And the upper, middle, and the lower zone, then we score each lung from 0 to 3. And this is assigned to each zone based on the lung abnormalities. We have score of 0, that's mean no lung abnormalities. 1 mean interstitial infiltrates. 2, it is for interstitial and alveolar infiltrates, but interstitial is predominant. 3, whereas the alveolar is the predominant finding. And the scores of 6 lung zone are then added to each other to obtain the whole score ranging from 0 to 18. As you see here, the score here is 0. Here is 1, where you can see the interstitial thickening, 2, alveolar opacity, and here is still. We'll go through the first case in my presentation. This is a 44 years old female patient, where you can see there is left perihilar airspace opacity, and the total score was 1. Another male patient with bilateral perihilar infiltrates, and this is interstitial thickening. So each lung scores 1 on each side, and the total was 2. And this radiograph, this is the initial chest radiograph. There is bilateral airspace opacity. On the right, the middle lung zone is affected, and on the left, you can see the upper and the lower zone. So the total was 3, 1 on the right and 2 on the left. Here also, the total score is 3. As you can see, right, middle, and lower lung zone are affected. And on the left side, only minimum opacity. So the total score was 3. The right is 2, and the left is 1. Here, bilateral, middle, and lower loop are affected. So giving each one a score of 2, the total is 4. Here is the same. And for this patient who's complaining of shortness of breath with fever and cough, he has a right middle and a predominantly right middle lung zone opacification, and on the left side there is left upper and lower lung zone consolidation, giving the score of 5, 2 on the right and 3 on the left. Well, this is from my last trip. Do you know where is this place? Anyone knows? Yeah. Yeah, from Aswan. This is the Nile River. We have this patient, we follow up this patient through several days. This is 52 years old, male patient with positive COVID-19 virus. This is the initial chest radiograph for the patient. So we can see right middle and lower lung zone affected and left lower lung zone. So the total score was 3, 2 on the right and 1 on the left side. After the third day, the consolidation increased on the left side, so the score became 2. Became 2 on the left side, so the total was 4. On the following 5th day, the findings were the same. The 8th day shows also the same consolidation affecting the right and left, middle and lower lung zones, and just we see there is an increase in the interstitial thickening. Also, the findings are the same on the 12th day. Okay, this is a 48 years old with positive COVID-19 virus. This is the initial just radiograph for the patient, which shows airspace conservation opacity on the periphery on each lung. On the right, the lung, the middle and lower zone, and also on the left side, the middle and lower zone. So each lung scores 2, the total is 4. This is the follow-up of the same patient on the 3rd day. The consolidation almost the same, but we have a new finding of right pleural effusion. The 6th day, the findings were the same on the follow-up. This is a 41 years old female with positive COVID-19 virus. So this is the initial chest radiograph was normal. I would like to highlight about the limitation of the chest radiograph during the first first presentation of the patient. We can have a normal chest radiograph. So the following 3rd day, the patient developed the left lung opacity, which scores 1. And on the 18th day of the follow-up, this opacity was faded, but there's still residual, as you can see. References and thank you. Any questions?
اي اسئله على الزوم لو في اي اسئله شات ممكن نرد عليها لو في اي حاجه next topic ان شاء الله وحصل على ماجستير في الفيزياء الطبية
Thank you for coming to our presentation. I want to talk today about patient load and computer tomography. We will start talk about taking introduction. What is the difference between idea and clinical study? Some expression used to calculate dose and digital effect not to receive the bank of model the compound of the tantric X-ray to produce the X-ray and remove low energy and then عشان تحدد العضو طيب طبعا الجانتري راح يلف حوالين المريض عشان تطلع له الصور. نفس الفكره طبعا بياخذ وقت هو يصور بعدين يترجم مصوره بعدين يروح برا بس هنا الفرق حيكون عندنا مكتب الديتكتور والبيم راح يكون ماشي ثيرد جنريشن هو المستخدم حاليا عندنا هو والاكس راي البيم راح يكون فان شيب اكس راي وقت التصوير حياخذ 5 سكند فورث جنريشن البرنسبل حقتها روتيتد بيكسل حيكون عشان الديتكتور ثابت يلف حوالين المريض فقط الاكس راي تيوب هو اللي راح يلف حوالين المريض. Sometimes described as generation electron. electron beam scanner. هنا ما راح يكون عندنا تيوب اكس راي، راح يكون عندنا فقط الكترون جان حيخرج لي الكترونات بعدين راح
اسمع اقول لك هذا انتم كاتبين شو اسمه مش كيف اظهر عندنا ليش؟ ها؟ ما في الدبره محمد ايش؟ لا اللي كاتبين مصطفى اصلا سويت والله ما يرد علي مرجو ضاع دقتها ضاع تاكدت انا ماشي شو تلقى عن ضاع اللي قال لما جت
The phantom is an object to replace for
وعلى اساس يقولهم على اساس
طبعا احنا لما نقرا اي ارتكل مكتوب فيها the patient receive 5 grade احنا نقصد فيها الفوليوم تي دي اي فراح نبدا نتعرف على تي دي اي تي دوز انتري عشان عشان توصف لنا الكبدي. لهذا السي تي حددت لنا ايش الاجزاء اللي سوى عليها الدراسه، كان الهيد، abdomen and pelvis, chest and neck and neck. حددت لنا ايش فاختارت مستشفى الملك فيصل تخصصي في الرياض، وعملت عليها دراسه حوالي 9 اشهر، اخذت من المرضى. فالعينة هذه أخذوا منها 75% بناء على الفحوصات، فالبيشنت اللي سوى أكثر من فحص استبعد، فكانت هذه نتيجة العينة. بعد قامت قامت هيئة الغذاء والدواء اختارت 10 مستشفيات عشان تزيد فيها عدد الدراسة، وتشوف إذا كانت مختلفة إذا تعاملت في مناطق مختلفة من المملكة هل يؤثر عليها أو لا. فوجدت إنه في CDDI فوليوم مستويات اللي طلعت لنا ممتازة مقارنة بالأمريكان كوليدج وباليوروبيان يونيون. وفي DLB كنا إحنا مستوياتنا أعلى بشيء بسيط. 2021 زادت الدراسة 4 مستشفيات أضافتها للولادة والأطفال في الدمام وبريدة وحفر الباطن ومكة المكرمة. نفس الفحوصات بس زادت للأطفال الهيد. فطلعت لنا هذه الفحوصات طلعت لنا في التيبل الأول DLB أقل من أستراليا واليابان حدود الجرعة. والدي والCCDI سوري أنا آسفة، الCCDI إحنا أقل والDLB إحنا أعلى منها. فكانت حتى الفروقات جدا بسيطة، فاعتمدوا لنا هي من ناحية إنه نعتمدها في جرعات البيشنت لما نحسبها. والجدول الثاني للبالغ. طيب احنا نعرف انه CT هو اكثر موديليتي ريسيفد هاي دوز مقارنه بالاكس راي والفلورو. فاحنا زي ما ذكرت لاحظنا انه الناتشرال باك جراوند لما نتعرض لها حيكون فور اكزامبل اذا الشخص عمل فحص abdomen and pelvis كأنه أتعرض ل3 سنين في الناتشرال باك جراوند. فهذا يعتبر مرة شيء عالي، فلازم ما يتعمل أي أحد الفحص إلا إذا كان محتاج. طيب after the DNA received X-ray ممكن يحصل لنا 3 أشياء. No effect, so the DNA can repair correctly. Stochastic effect, the DNA repeat itself incorrectly, or deterministic effect, السيل راح يصير لها. طبعا احنا راح يهمنا أكثر حاجة الستاتستيك effect والdeterministic effect. Stochastic effect تأثيرها ما بيبان حاليا وتعتمد على الدوز، كل ما زادت الدوز كل ما زادت تأثيرها. الديترمينستيك افكت تأثيرها حيكون لحظي ويبان معتمد على الدوز. فمثلا لو البيشنت تعرض من 5 ل 10 جراي راح يكون عنده حروق، او لو اخذ 4 جراي راح يكون عنده حيفقد شعر. بالمقابل غالبا بيصيب الوركر لانه جرعه الاشعه اللي بيتعرض لها قليله، فبس بتزيد مع الوقت، فاحتماليه التعرض لكانسر والجيناتيك افكت. لازم ننتبه على نفسنا. Cases received high dose. First case عندنا over 18 months 206 tinter in Los Angeles received 3 to 4 grade, hit greater than expect 0.4 grade, but wasn't detected until one patient declared hair loss. Cause was stroke patient and exposed to 8 times the normal radiation during CT scan. طبعا كانت المشكلة هنا إنه patient لما فقد شعره لاحظوا إنه في مشكلة، فطلعت المشكلة إنه ما تعمل QC مضبوط للجهاز، إنه حطوا نيو بروتوكول. زي ما ذكرت أول، الجهاز بيعطينا estimation للدوز اللي الشخص بياخذ، فلو الشخص ما أخذ نفس هذه الدوز أخذها بطريقة مختلفة حتسبب أضرار زي ما ذكرنا هنا. فلازم نتعمل له QC وهذه المهام الميديكال. الحالة الثانية كانت في كاليفورنيا، عبارة عن تكنولوجيست أعاد تصوير المريض 51 مرة، سببت له حروق للطفل، فكان عذره إنه زاد عدد التصوير بسبب إنه الطفل كان بيتحرك، والده كان بيحط يده، فمفروض ننتبه أكثر وما نعيد.
شكرا أستاذ. Next topic will be the CT chest imaging features and the severity score for assessing COVID-19. Topic will be presented by Dr. Al-Alami, supervised by Dr. Hania Sobhi. So, Dr. Nahla, Dr. Ubaida is one of the residents too, and supervised by Dr. Hania Sobhi of South Africa.
Assalamu alaikum, everybody. This is Dr. Al-Alami, R2 radiologist resident. Today I'm going to represent the CT features and of the features the effective way to discover any parenchymal abnormalities in COVID patients. Okay, in some regions it was the primary method for detecting any abnormality, and that was the beginning of the pandemic. Okay, epidemic disease. Okay, so. But unfortunately, the CT having a very high sensitivity, it's reaching about 90%. But as I said, unfortunately, the specificity will be very low. Why? Because the other viral infections like SARS can give the same appearance of COVID patients. Okay. Now, for the typical finding in CT chest for COVID patients, as we know, the most important or the most typical representation is the mixed opposites, which is made representing ground glass opposites, consolidation, or even mixed between. Also, the crazy breathing appearance, it's one of the most common representation during the later stage, followed by reversed halocyan and the spider web. Also, there is some of atypical representations such as the apical distribution or the apical involvement of pulmonary segments and lymphadenopathy. Some of the very atypical representation is the presence of some cavitations or calcification or three-implant appearance. Okay, now I'm going to start the cord classification, but before that, there is some important point to mention. First, the cord classification was dependent on the assess how the level of suspicious for this patient to develop COVID-19. And it was start grading from 1 to 5 in case one going to be a no suspicious or very low level of suspicious. And 5 going to be a very high level of suspicious, okay? So, but again, if we wanted to look for the severity or the cause of disease, we need to assess the patient clinically by looking for the comorbidities or the underlying pulmonary disease the patient may have. Okay, so this is a picture of correct classification. As we mentioned, 1 is going to be there is no suspicious or very low suspicious. 2 going to be low but higher than 1. 3 going to be intermediate, and then 5 very high but positive, and 6 going to be positive PCR.
برضه موجود. كمل معك. هنا انت. كمل.
Okay, now I'm going to talk in detail about the correct classification. 1, as I mentioned before, either the patient have no suspicious of COVID or very low suspicious. In those patients, mainly the CT abnormality, the CT findings either being a normal, totally normal CT, or having a non-infection disease appearance, like if the patient was having congestive heart failure, septic emboli, or maybe malignancies or histoplasmosis. Okay, this patient here, as we see in the right side of image, we're going to see totally normal CT chest with negative PCR, and this patient was on the 5th day of compliance. The next classification is 2, number 2, and the level of suspicious here is very low.
Can we change the screen? The screen not moved,
infections,
please.
such as typical bronchiolitis or re-implant and thickened bronchus and so on. Again, in this class, there is no typical features of COVID-19. Okay, here this patient, as we can see, there is some of it re-implant appearance and some of the bronchiectasis. So there is no grounded glass opacity, which is the most typical representation. For hereditary, we can see this patient having intermediate level of suspicious. The CT findings going to indicate infection, but unsure if the infection was related to COVID is involved or not. Okay, sometimes the patient may have just the widespread of a bronchopneumonia, lobar pneumonia, septic emboli with association of grounded glass opacities. Okay, as we can see here, the 4 patients was having such of unifocal grounded glass opacities was mentioned here, but there is no any other typical findings. So now the next one is the correct form. Correct form, we start to be having a higher level of suspicious, but unfortunately, those patients may be having some of extremely atypical findings. For example, maybe we found unilateral grounded glass opacities, or maybe we found consolidation with no other typical findings, or maybe unfortunately the patients going to be having some of underlying pulmonary disease. Okay, so who can tell this patient COVID or not? So we're going to correlate with PCR. Okay, now for this, for example, as I mentioned, these patients who's having here, we're going to see there is unifocal grounded glass opacity was mentioned, was noted only on the left side of the lung, while the right was totally normal. So this is one of the atypical findings. The next patient was having a ground glass opacities bilaterally, but unfortunately there is some obtained wall cyst, which is compatible with emphysematous changes. Okay, now for CORAT 5, we have mostly in those patients, this level of suspicious gamma to be very high, and the patients mainly get into having a lot of typical features. At least we will solve two. For those patients, we can see there is a ground glass opacities bilaterally associated with consolidation. Okay, again, those patients having bilateral crazy bleeding appearance, which is mainly using those words to represent two important features, ground glass opacities and associated with interlobal septal. Okay. Finally, the correct
Excuse me, your slide.
Finally, having positive PCR. Here we can notice the reversed hull slide.
Slide is not changed.
Okay. So we was there in the correct 6. Now I'm going to move to some of our cases from here, our hospital. Okay, this is some of our cases here in hospital. I will start with this 47-year-old man who was presented with osteoarthritis of the This patient was presented on the 7th of December. We can see here there is a bilateral air space opacity seen mainly posterior and basal involvement, while the cardiac control was
ما شفنا الحالات
After
السابقة.
2 days follow-up, we can see there is a significant progression of the disease. Now only we have 25% of the lung was spared. So after a couple of days, the CT follow-up was done for this patient because the patient keep desalting and keep needing for oxygen. So we found in the CT, actually by naked eye, you can see there is a decrease in lung volume of the right side comparing to the left, associated with the ground glass opacities and some interlobal thickening, mainly demonstrating that the peripheral and basal. As we can see here, there is some sort of mild detraction bronchiectasis. And this is another view for this patient, the coronary view, which supports our diagnosis by the typical presentation of peripheral and basal predominantly. Okay, for those patients, we have a high level of suspicious, but because the patient was having a positive PCR, so I'm going to score this patient with CORAT 6. The next patient is 59 years old female patient who was presented to the ER with history of cough and shortness of breath. The patient was admitted to ICU after desatting. So this is the X-ray and the CT chest of this patient. We got 2 axial cuts and 1 of coronal. The axial cut was showing peripheral ground glass opacities with some sort of consolidation, which is those with the typical appearance of the COVID-19. So there is a high level of suspicious with CORAT 5 for this patient. Okay, there is a 46-year-old male patient who presented to the ER with history of hypoxia. As we can see here, by these 2 cuts, I'm going to say this patient had 2 atypical presentations. The first one is the apical involvements of the left lung, and the second one is the unilateral ground glass opacities. Okay, so if we move to the another cuts, we can see here there is some sort of ground glass opacity on the other side, and there is some sort of compressive atelectasis, which is again goes with the typical presentation of CORAT. This patient have a high level of suspicious with CORAT 5. The last patient is a 66-year-old male patient who is positive COVID. Again, we saw in this patient there was a bilateral crazy bleeding appearance, with the spread of the apical segments, which is goes again with typical presentation. This is another with the same patients. And again, it's highly suspicious with Corad 6 because of positive PCR. That's it, and thank you for your attention. If anybody have any question, I'm working on with Dr. Ryan.
السلام عليكم زوالين. دلوقتي الحاله اللي بعتها لك امبارح اللي كانت كاشفه عن النساء شفتها اللي قلت لك الست دي نفعت تمشي يعني مشيت عندهم في التامين؟ هو انا كلمت دكتور ماجد بقول له دكتور ماجد هو كان في حاله برضه عنده ما كانش يعرف ان هي كان عند الدكتور شاوي وعند الدكتور عمر خليل. قلت له انت خلي بالك قدامك في حاله
الزملاء على
ما بعرفش يعرف ان هو كشف قبل كده ولا لا؟
حوالي ساعة.
طب انتوا مش داجين
إن شاء الله هنرجع نكمل على الساعة 12 بإذن الله.
طيب النهارده في واحد اهو. انت المواضيع دي تهمك انا بقولها ولا مش فارقه؟ المواضيع بتحلها انت بعدين. هل انت مربط مع حد مثلا جوه الشركه انا عارف من غير ما اتكلم بصراحه يعني بياخدوا ساعات حاجات الموظفين ويمشوا المسائل سواء خد يعني 1 4 2 1 5 8 1 4 2 1 ده اخ جالي راجل عجوز اسمه عبد علي محمد علي ده كشف عظام وكشف بس اعتقد ده بوردر لاين يعني ممكن يكون زاد حاجه بسيطه. عمل اشعاعات كتير انه عمل اشعاعات حوالي 4 اشعاعات وعامل شوف انت بقى انت ادرى ماشي. وفي لسه في علاج هياخده سواء في البطنه وفي العظم. ما هو في علاجات وفي فحوص عمليه. انت راجع بقى انا بس لما بلاقي فحوص ومحمد عمر كمان عمل لا مش محمد عمر اسف عمر خليل اللي عمل له برضه عمل له تحاليل معمليه وبيدي له علاج. فانت شوف بقى ظبط امورك.
يصير من بكرة آخر تطبيق كامل شكل باخذ نص ساعة. شوف باخذ ساعتين بس عشان
بس عبالي قاعدة أمشي وأفكر أبي أطلع بس أقول يا رب أسوي أول الشهر.
كنت اليوم الأشعة العالمي ولا حاجة
كنت بحصل كم تكسب الشهر كثير.
بس إحنا اللي بعدين نحاسب مشكلة ما نعرف نسأل من يعني نسوي بقولك هي أحسن بس بعدين أو شو يوم امتحنوا كانوا تقولوا إيه أحسن إنزين إيه تحسبي بس هذا حاجة اللي قاعدين يطلعوا
من إجازة ما أشوفها.
جوالك هذا مفتوح
السلام عليكم.
السلام عليكم. حبيبي ازيك يا جميل؟ والله الحمد لله تمام. كله تمام؟
دكتور انا عندي مشكله بالرجل، كأن مسمار نضع في الرجل هذا. في ألم بس ما في شيء، ما اشوف شيء.
طب ما تخلي طبيب العظام يشوف، جايز يكون التهاب في الانسجه اللي هي بتاعت مش انت لما بتيجي تدعس تحس بالالم.
الحين اقوم من الاقل، اقوم اطلع عليها تحس في مسمار، في مسمار السماء.
مسمار القدم يعني؟
ايه.
بس هو في حاجه موجوده فيه؟
في حاجه ما ادري.
لو في حاجه زي كده بيبقى عن طريق الباطنيه بيسووا تحويل الجلديه هناك. الجلديه لان لهم مسمار القدم ده علاجه كله جلديه.
شو العلاج؟
بيدوا يا اما ماده كاويه يا اما بيدوا بنج موضعي وبيعملوا لها كي. وفي حاجه اسمها علاج ليزر دلوقتي، في حاجه اسمها علاج بالتبريد، في 100 طريقه علاج يعني بعيد عن الجراحه خالص.
طيب وهذا
ما ده نفس ده بيسموه كيس دهني، حاجه زي شبيهه بالكيس الدهني، وده مع طبيب العظام. فانت لو راجع طبيب العظام
بشيلها؟
نعم، ماذا اذا كان ممكن نشيلها هنا ولا لا؟
السلام عليكم يا جماعة، اللي فاتح المايك يقفله، اللي فاتح المايك يقفله. دكتور محمد يوسف.
عشان كيف يخرج؟ فين هذه؟ هذه؟
لا اللي فوق خالص، اللي فوق خالص احنا لا ترجع ترجع
واو هم كده. اهلا وسهلا. ما رحتوا لفوديالو انتم كمان؟ بس ما يحتاج، حتى انا ما يحتاج، حسب جد اسمه بس من جد. ايش هنسوي؟ انا ادري. ايوه دريل قالوا. دكتور بندر نعم. هلا هلا تعالي تعالي. يا سلام تنورين. صح؟ من جد. بس أطفالاتي يوم السبت هي مسكت حالها. خلي بس خافي الله. لا ما هي مؤذية، هاي تينها كتكوتة والله انها كتكوتة. مستحي مستحي كمان. شوف وجهك بليلة. عادي قولي جاملي استحي. ايش بهم سلامتهم. احسن ناس ليش تتكلمي عليهم؟ اسكت. كلهم احسن ناس. ايش فيه؟ حبايبي حبايبي. ما ادري ليش سوالف ليه؟ مو كله دخل ايوه هم يحبوا. طب عشان برمش فوق راسه. محمد حسن ما شاء الله ما يضحك تلقى دكتورة. هو اليوم ما شاء الله مرة فاكر ضحك. خلاص ضبطت لك الموضوع. امي في شيء ان شاء الله بسلامه. وانا كلش كنت على طول تروح بكتم وتلاقي سهوله. تمام. الوحده اسمها ايمان في بنك الدم. طيب وتقول لها انا من ضيف وقريب بس تقول لي في تروح الوحده اسمها ايمان. خلاص يا حبيبي. لما تيجي ان شاء الله تدخل على طول عند بنك الدم. تروح الوحده اسمها ايمان وتقول لها انا من طرف رقيب بس رقيب لا انا بفرفر بيه، هي خلاص ضبطت معاها، بس لما تيجي يصير تسحب لها الدم. تمام، خلاص وقت ما تدخل خلاص، بس لا تتاخر. ممتاز ممتاز، خلاص تمام. ايوه خلاص. طيب يلا حبيبي، يلا ولا منك حبيبي. شوفها طالعة. ايش هو؟ ايش هي؟ روحي ما هتلاقي ولا حبة. اسكت. روحي عندها. طيب روحي. عواطف لازم لسه مو كلير صح؟ اليوم الكود يلو صح؟ مو كلير، ما قالوا كلير لسه صح؟ طيب والله حتى كنا بس نساعد. يلا شوفوا عندها خطة. نجيب الطلبة هنا وتبدها كده ايوه عشان ما ايوه ما ندري جينا كذا. ايوه هو الإحدى بس يفتح ايش ده؟ ايش اللي نزلوا ده؟ ايش اللي يعني اليوم سرير لا بيجلسوا عليه. ايوه هذا اخر شيء. لا هذا انا ما اعرف. يلا سكي حتضرب ضرب حيصير طبيخ. ايوه هذا نخليه كذا بالعكس احسن ايوه صح. ايوه نرتب الغرفه بس زي كذا انا قاعده في صف اهل العروسه ولا العريس. يلا نستقبل الضيوف حقهم بشاير. ضيف بشاير عشان هي بتتزوج ان شاء الله يا رب. أنا ما يسمع شيء.
أبغى غرفة خاصة وما لقيت. أنا أعطيت عمر إني ألاقي كويس. ذكرتني بكروت داخل على أي أساس؟ أنا أخاف تقوم يوم ما جت عيادة النساء.
ها؟ طوارئ؟ شيء؟ الدكاترة في هناك الطوارئ. إيه. ثلج
السلام عليكم، سامعني يا أخي؟
السلام عليكم ورحمة الله وبركاته. لو سمحت ما في صوت. السلام عليكم، في صوت تسمعوني؟ في صوت أو الصوت ما هو واضح؟ يا دكتور، عندك مشكلة في الصوت، الله يحفظك. ما ودنا تكمل لأنه ما احنا جالسين نسمعك.
الو السلام عليكم، صوت واضح يا جماعه؟ صوت وصلكم دلوقتي؟ انا سامع صوت.
صوتك بعيد، الله يحفظك، وفي صدى.
الو يا جماعه الصوت واضح؟
ايوه حطيته هنا.
لا. الو السلام عليكم. الصوت موجود يا جماعه؟ سامعين الصوت؟
احنا عاملين كمان هنا بعد
ايوه السلام عليكم.
انا اللي فاتحه.
كمل.
Examples of the bronchoalveolar disease in COVID patients. COVID patients can develop pulmonary embolism, deep vein thrombosis, ischemic stroke, myocardial infarctions, and bowel ischemia. In my presentation today, I will talk about the pulmonary embolism. What is the causes of pulmonary embolism in COVID patients? Some studies said that there is direct invasion of the endothelium of the blood vessels by the virus itself. And other studies said that the hypercoagulable state in COVID patients caused by excessive inflammation, hypoxia, and immobilization contributes to a prothrombic state. Most of these patients have high D-dimer and high fibrinogen levels in the blood. Pulmonary embolism and deep vein thrombosis occur in 17% of COVID patients, and 15% of these patients primarily have this embolism in the acute phase of infection, and more commonly in the patient admitted in the ICU. 2/3 of pulmonary embolism patients having in the acute setting are found in the segmental and subsegmental branches. Evaluation of pulmonary emboli should be considered in patients with pulmonary symptoms unexplained by imaging or unexplained reduction in oxygen saturation. These are some examples of pulmonary embolism in COVID patients. In this case, the patient have filling defect in the right interlobar artery, seen in the soft tissue window. And in the lung window, we can see a wedge-shaped ground glass opacity in the right middle lobe periphery, indicating pulmonary infarction. And these changes in the lung basis for COVID infection. This is another example of patient in the ICU with acute respiratory distress syndrome. You can see the lung changes of COVID. And then this patient have a filling defect in the right lower lobe.
دكتورة مفيش صوت مش عارف ليه. جوين دكتورة معلش جوين الاوديو كده جوين.
Almost there.
صوت الدكتورة واضح.
الصوت في حد لما بيدخل بيعمل ديسبيتنج بيصاد الصوت دوت.
اسمع يا ستة. صوتي واضح؟
صوتك واضح بس الصدى بتسويه الجوالات إذا أحد مشغل الجوال وفاتحه وقريب من المايك هو اللي بيسوي الصدى.
سامعني؟ لو الزملاء اللي على الزوم في صدى صوت
من عندي لاني انا اللي فاتحه الهاتف فبيسمعوا.
ممكن تأكدوا علينا الزملاء في الصوت معلش مرة ثانية.
يعني يكون عمل صبغة يعني عادي بعدها يسوي؟
إذا كان راس لازم 48 ساعة، في ناس 24.
يعني عادي بعدها أسبوع كده.
أيوه.
يسوي التحليل.
Complete diagnostic test for the non-invasive diagnosis. Results. So a perfusion CT is not an accurate diagnostic test for pulmonary embolism diagnosis, as a positive test has an unacceptable high likelihood for be a false positive result. So we will continue. So what is the implication of false positive diagnostic test in a patient with suspected acute pulmonary embolism? The anticoagulant therapy associated with a risk of bleeding, and once the diagnostic test has been reported as a positive for pulmonary embolism, even if the clinical probability is low and the other tests are negative, the benefit of doubt makes it difficult for the referring physician not to treat the patient with anticoagulant therapy as an efficient treatment to prevent potentially fatal recurrence. False positive test, lung scintigraphy with main lifelong anticoagulant therapy and its risk for many patients. In women, other implications of PE diagnosis include daily heparin injection during any subsequent pregnancy and a definitive contraindication to any hormone therapy, including the birth control pill. So in this last study, they propose a different approach with a diagnostic algorithm to limit the imaging to appropriate patient and minimize performance of ventilation study. In the perfusion scan, if the perfusion scan doesn't show any segmental defect, the scan is deemed to be negative for PE. Even if the perfusion scan demonstrates segmental defect, the scan should be interpreted as indeterminate and the patient referred for alternate testing. So if the perfusion scan is negative, so there is 100% no PE. But high proportion of COVID-19 patients with respiratory symptoms are unlikely to have a strictly normal perfusion scan. Furthermore, given the most of the COVID-19 patients referred for a lung scan are those with contraindication to CT pulmonary angiogram. And alternative test is likely to be repeat the lung scintigraphy with ventilation study. So the last recommendation, while the risk of contamination due to the inhalation procedure exists and must be taken into account, it can be considerably reduced by appropriate personal equipment. In COVID-19 patients, as long as there is no shortage of personal protective equipment for healthcare workers, including the mask, eye protection, gloves, and gown, recommended to perform both perfusion and ventilation studies. So in summary, if a lung scan is required in patient with suspected PE, we would recommend performing both ventilation and perfusion scintigraphy with appropriate resolve precaution for technologists. Thank you. Please, if there is any question, write it in the chat.
Assalamu alaikum. Thank you, Dr. Sosa. Next topic will be about the neurological findings in COVID-19 patients. The topic heard by Dr. Stanley, the neurology consultant, complex, and the presentation will be done by Dr. Mustafa Chihu, senior registrar also in our department. In the next couple of minutes, we're going to be running through new findings in patients with COVID-19. It's a pleasure to be here. As a form of introduction, we all know that the COVID-19 has been designated a pandemic, and over the course of time, some researchers are considering it to be an endemic disease that will have a long standing with us. As a result of this, a lot of studies have been done regarding to look at the disease burden of COVID-19 in patients over the last 1.5 years. A lot of disease burden manifests in different parts of the body, including the chest, and the neurologic system is not left out. As a result of this, researchers have documented during the period of the pandemic different manifestations seen on neuroimaging, on CTs and MRI, in order to help us to manage our patients better and identify these findings as quickly as possible. In the course of this discourse, we are going to be talking about the pathophysiology of the disease, the manifestations on imaging, and then we are going to mention those imaging findings that are very common and which nobody should miss, or which we should try as much as possible to be familiar with in order to help our management. In terms of pathogenesis, pathophysiology of the disease, 4 very broad categories have been identified as possible causes for the neuroimaging findings that are seen in COVID-19. One is direct viral infection, which occurs through neuroinvasion. This has been identified in various studies and has been explained to be what is responsible for the anosmia that patients with COVID-19 have. Secondly, it's parainfectious immune response to the virus, which usually manifests as a coagulopathy, which occurs via direct invasion of vessels, as previously mentioned by one of the speakers, as well as cytokine storm, which we all know has been identified in patients with large burden of COVID-19 disease. Another physiologic pathway is that of post-infectious delayed immune response, which was later seen in patients who have had COVID-19 have delayed manifestations in the neurologic system. And lastly, complications due to prolonged stay in the hospital. A lot of patients have long stay in the ICU, hospitalization needing some intervention, such as echo, dialysis, and the likes, which also contributes to the imaging findings that we see in this patient. Of all these pathophysiological processes mentioned, the most important or the most widely documented is coagulopathy. And this coagulopathy has been said to lead to thromboembolism, and it is well seen in patients with high burden of the disease. Coagulopathy has been explained like I earlier mentioned, to occur via cytokine storm, which is regarded as a dysregulated and excessive immune response that can cause immune-mediated tissue damage. This tissue damage leads to pro-inflammatory cytokines that results in endothelial dysfunction, vascular damage, activation of the coagulation cascade, invariably leads to a hypercoagulable state. The alternative to this process is direct invasion. Some researchers have documented there is direct invasion of endothelial cells of vessels or endothelial lining of vessels, as well as some muscular invasion, muscular invasion of the heart, which leads to the same cascade of process leading to hypercoagulable states. Of note is that patients in the early onset of COVID-19, patients who were young were seen to have large thromboembolism, despite the fact that they did not have a large burden of inflammatory changes in their chest, which also addresses the fact that, or the importance of endothelial in the pathogenesis of the neurologic symptoms. Also in the pathogenesis, as we mentioned earlier, is the long stay patients with COVID in the hospital, some of them requiring ICU admission, a lot of them requiring intervention. It also leads to things like diffuse hypoxic injury to the brain, microhemorrhages, and delayed post-hypoxic microencephalopathy. This table just gives us a summary of almost what we're going to be talking about, linking the pathogenesis of the disease to the clinical syndromes that we see in patients with COVID-19. Importantly, this neuroinvasion, like I have mentioned, has been said to be responsible for anosmia, and the endotheliopathy responsible for thromboembolism. Infectious disease, infectious manifestation of the disease, whose cytokine storm has been responsible for these clinical syndromes, like acute necrotizing microencephalopathies, encephalitis, cytotoxic lesions of the corpus callosum. The important note is cytotoxic lesions of the corpus callosum, which is said to be as a result of high glutamate receptors within the corpus callosum, especially in the splenum of the corpus callosum, leading to manifestations of microhemorrhages in this area. Post-infectious delayed immune response has also been identified, leading to Guillain-Barré syndrome and acute disseminated encephalomyelitis. Prolonged hospital stay, dialysis-related post-reversible encephalopathy syndrome has also been identified. Now going to the imaging findings. Most patients who had COVID-19 undergoing neuroimaging in the early onset of the disease were described to have had a non-specific white matter microangiopathy in the early onset, within 2 weeks to 1 month of the disease. However, as the disease progresses, some patients began to manifest with acute and subacute infarctions and hemorrhages. So in essence, the most widely documented findings are microangiopathy, which in itself may not be due to the COVID-19 itself, but also it could be because the patient has had this disease body. Maybe they have comorbidities like diabetes, hypertension, which manifest as microangiopathy as well. And most studies next to this are subacute and acute infarctions in patients with COVID-19. Then next to that is hemorrhage. These hemorrhages can be microhemorrhages or large hemorrhagic foci. The imaging findings. These are the spectrum of imaging findings that have been reported in the studies so far. Ongoing studies are still being done. Like I mentioned earlier, that in the early period of the pandemic, thromboembolic manifestation and hemorrhages were those findings that were mostly reported over time: delayed manifestations, meningitis and encephalitis were described, and cranial nerve enhancements were also described, as well as manifestations, which we are going to run through in the next couple of minutes. Thromboembolism. Like we all know, a lot of patients in the pandemic had thromboembolism, which we have described as a result of patients. Lots of the patients manifested with large vessel occlusions, as well as large infarction, peritoneal infarctions, branch vessel occlusions, small vessel occlusions, and the likes. To a lesser extent, patients had venous infarction. Only a few. It has been described that venous infarction was less likely in patients with COVID-19. A lot of researches are still going on in this respect. Patients with COVID-19 and acute thromboembolic infarct may also have high clot volume. The vertebral artery has been described also in the lower limb that they have DVT. Also pulmonary embolism, like mentioned by the earlier speakers. Now to the imaging findings. This is a patient who was admitted with positive COVID-19. Patients had right-sided weakness, and eventually CT was done. The imaging CT was initially negative. However, CT angio was done, which showed an abrupt cutoff of the left correspondingly, in the brain, there was hypoperfusion in the region of the anterior cerebral artery as well as the middle cerebral artery. Lastly, we can see this is digital subtraction showing the thrombus within the vessel. We said thromboembolic infarctions is common. In this case, is a patient with middle cerebral artery occlusion leading to acute infarctions. These are ganglia here in the middle cerebral artery territory. Also, importantly, was that some other patients manifested infarctions, not just in one arterial territory. Like this patient, this is the same patient, figure C and D, diffusion images showing anterior middle cerebral territory infarction as well as posterior circulation infarction, which also emphasizes the point that these patients might have had a kind of showering emboli coming from over the heart or the aorta or distal vessels, or rather bottom of vessels. Also, this is another patient who was seen, COVID-19 patient, 61-year-old patient, 41-year-old patient who had hemorrhagic foci on CT. This patient subsequently had an MRI. Area of diffusion restriction just adjacent to the area of hemorrhage, which shows that some of these patients who have infarction have an issue which transformed into a hemorrhagic infarction or with hemorrhagic condition. This is another patient, the rare form of venous infarction in patients with COVID-19. This patient had an area of hypodensity in the temporal lobe with areas of hemorrhage, subsequently had an MRI. This is subcentrifugal weighted imaging, which showed area of low signal within the temporal lobe on the right side. This is corresponding flare signal. And when the MRV was done, it showed that the patient had a complete occlusion of the transverse sinuses, sigmoid sinuses on the same side, which is diagnostic for venous infarction. This patient also had COVID-19. Next is hemorrhages. Hemorrhages have been described to manifest in patients with COVID-19 as a result of one, in patterns such as lobar hemorrhages, microhemorrhages, subarachnoid hemorrhage, and subdural hemorrhage. All of these have been described. These intracranial hemorrhages in COVID-19 are said to be a a result of complex interplay of different pathologic processes, both thrombin states, cytokine storm, and treatment-related complications. Most of the hemorrhages could also result from patients who have been on long stay in the hospital and had treatment for thromboprophylaxis, hemodialysis, and ECMO. We have a lot of patients with this have also seemed to have hemorrhages. Here is a 61-year-old patient who had COVID-19. The patient was hypoxic for a long time, had to be intubated, had ECMO done. Eventually, the patient was seen to be having dilated fixed pupil. And then a CT was ordered for the patient, and the patient was found out to have a large hemorrhage centered around the basal ganglia on the right side here, which have ventricular extension and a lot of hemorrhages, subarachnoid hemorrhages, and small hemorrhages around the brain. Also, the patient had midline shift and some hydrocephalus on the other side. This is another patient who had subacute infarction. You can see we did the diffusion weighted image. The patient has some degree of restriction, which was with ADC, although not shown here. ADC corresponding hypointensity on ADC, which suggests some acute infarction. The same patient had hemorrhages as seen on this substitutable weighted imaging with low signals in the brain as well as at the level of the corpus callosum, which underscores the fact that patients with COVID-19 may have both processes, both an infarction and hemorrhage. And these hemorrhages, like we said earlier on, that some patients had manifestations because of their high glutamate receptors in corpus callosum. They had predilection for manifestations such as hemorrhages in them. Next is leukoencephalopathy. Usually, some patients with prolonged ICU stay for COVID-19 had manifestations described to be symmetrically confluent white matter hyperintensities on T2 weighted imaging with somewhat restricted diffusion, with a relative sparing of the juxta cortical and infartentorial white matter. We have here another patient with COVID-19. If we look closely here at the flare images, we could see areas of hyperintensities around here, which was well manifested in the diffusion weighted image as areas of hyperintensity. Although the ADC is not shown, showed some degree of variable restriction. In addition, this patient had at the basal ganglia areas of microhemorrhages, which underscores the fact that, again, that microhemorrhages are well documented in patients with COVID-19. Globally is hypoxic injury. Also, patients who had COVID-19 as a result of long hospital stay, some of them have persistent hypoxia. It may lead to them having global hypoxic injury in the brain, which usually manifests on MRI as restricted diffusion. Some of the patients also have necrosis of the globus pallidus. This is an MRI of a patient with hypoxic injury. You can see on flare signal that there are areas of hyperintensity in the basal ganglia. This patient on diffusion weighted imaging had some diffusion restriction. Meningitis and encephalitis, although this has been described to be less common, for a couple of patients have manifested signs of encephalitis with COVID burden. Most described is ADEM, that is acute disseminated encephalomyelitis, is what's mostly described in these patients with COVID-19. And usually It follows an upper respiratory tract infection or immunization in children and young adults, and most likely represents an autoimmune response to these triggers. ADEM may involve the brain or the spinal cord, but most typically it involves the subcortical central white matter lesions and lesions at the cortical gray white matter junction. Although periventricular white matter and gray matter of the cortex will also be involved. Another fulminant type or fulminant form of ADEM, which is acute hemorrhagic leukoencephalitis, has also been described. And this acute hemorrhagic leukoencephalitis exhibits complex, large, non-enhancing subcortical white matter lesions with relative sparing of the cortex, and associated hemorrhagic foci seen in them. Here is a patient who had COVID-19 after day 21. The patient had an MRI, and here's a flare sequence showing areas of hyperintensity, just subcortical and periventricular hyperintensity with scattered white matter hyperintensity seen. Here is diffusion weighted imaging showing some areas of it's increased signal, but if we look at this one closely here, we do not see the hyperintensity as here. And correspondingly in the ADC, some of these lesions showed signal drop, while some did not have corresponding diffusion restriction, which is consistent or which suggests a demyelinating disease such as ADEM. Like we mentioned, ADEM can also manifest in the spinal cord. Here's a patient with areas of hyperintensity on STEER imaging at the conus and along the cord. The patient also had periventricular and white matter hyperintensities with relative diffusion restriction. In this is an MRI of another patient with long hospital stay who had subsequently developed this finding on the flare. It's areas of high signal intensity seen on flare, and susceptible imaging showing areas of low signal, which shows hemorrhage. This patient was later diagnosed to have acute hemorrhagic leukoencephalitis, which is, like we said earlier, is a fulminant form of ADEM. So these are some of the spectrum of findings that were documented in patients who had COVID-19 with encephalitis. Like we earlier mentioned in the pathophysiology, that patients, because of the high cytokine storm, patients who had cytokine and glutamate receptors in the corpus callosum, make them an area for predilection for COVID-19, which usually manifests as foci of hemorrhages or microhemorrhages. Here's a patient who had COVID-19 and had areas of microhemorrhages along the corpus callosum, especially in the sclera. Let's see the low signal in these areas. Anosmia, although some researchers disagree with this, but a couple of cases have been mentioned or described in the literature that anosmia in patients with COVID-19 is as a result of direct neural invasion of the nerves because of the high burden initially of the COVID-19 virus in the nasopharynx. It is believed that there is some form of retrograde ascent of this virus via the olfactory nerve, which leads to some impairment of the nerve, leading to anosmia. On imaging, the patients had increased T2 signal and flare signal abnormality in the olfactory bulb and tract with subtle contrast enhancement. Here's an image of patients with anosmia who had imaging, coronal imaging. These post-contrast, flare images showed areas of hyperintensity. If you look closely, this is a normal patient, and this is a normal patient, and this is the patient who had anosmia. If you look at this, there is some high signal here compared to the normal patient, which has been documented in patients with anosmia. Here's another image showing bilateral enhancement along the ophthalmic nerve. Along the olfactory nerve, olfactory bulb rather, shows bilateral, although asymmetrical, compared to the normal patient. You can see that there is increased signal enhancement along this. Similarly, here's another patient that had anosmia. So which underscores the fact that patients with COVID-19 anosmia can have neurologic imaging findings in the olfactory bulb, some of them. Cranial nerve enhancement has also been described. Aside that of the olfactory bulb, other nerve involvements have been described, including the oculomotor nerve, some patients having optic neuritis, and the likes. Miller-Fisher syndrome has also been described, which is a variant of Guillain-Barré syndrome, which is an acute peripheral neuropathy that can develop after exposure to infectious pathogens, including viruses, and it is characterized by a triad of ophthalmoplegia, ataxia, and ear reflexia. Here is a patient who had COVID-19, had MRI done. This is post-contrast MRI, shows some enhancement bilaterally along the optic tract. Here, you can see there is some enhancement. And also in the posteriorly here along the tract, you can see some enhancement here, which has been described in some literature. Also, here is a patient with asymmetrical enhancement and enlargement of the left oculomotor nerve. You can see it properly in this coronal image. This is the left side, it's enlarged and enhanced as compared to the right side. This was also a COVID-19 patient. So this just underscores the fact that we can have enhancement in patients or some form of neuropathy in patients with COVID-19, which manifests as enhancement along the cranial nerves. Also, although I don't have a picture of it, there were some patients who had enhancement along trigeminal nerves and other nerves, including even the cauda equina in some patients, leading to spinal manifestations. Guillain-Barré syndrome may occur in patients with COVID-19, syndrome which is characterized on MRI by hyperintensity on T2-weighted MRI in the distal cord and enhancement of the caudal nerve roots on contrast-enhanced sequences. There is an MRI of a patient with on STEER imaging. You can see areas of hyperintensity along the cord here. On post-contrast examination, you can see some enhancement of the caudal equina nerve roots as they emerge here. So this has also been reported in patients with COVID-19. Lastly, like we mentioned in the pathophysiology, that some patients, because of their prolonged hospital stay and prolonged illnesses, they've had dialysis, they've had large volumes of their blood exchange. They manifest what we call PRESS, that's posterior reversible encephalopathy syndrome, which manifests on MRI as high signal areas in the posterior part of the brain, as we can see here. Also of note is that these although it is called posterior reversible, does not mean that we cannot find it in the anterior parts of the brain or the other parts of the brain apart from the hospital areas or the temporal areas. Like in this patient who has along the external capsule that have enhancement there, also in the thalamus, this patient had some high signal on the third imaging. So with this is the last image. In summary, what we have discussed quickly is the manifestations of patients with COVID in the neurologic symptoms, in the neurologic system, and a summary of the whole thing that we have discussed can be seen in this table. These are pathophysiologic processes that have been mentioned, and these are the possible clinical symptoms that we can see in patients with COVID-19. Most importantly for all of us is that we should know that patients with COVID-19 have a high coagulopathy state, and they could have thromboembolism. So we should have a high level of suspicion and try as much as possible to manage them as fast as we can, and to have a very low threshold to imaging them for neurological complications. Thank you very much for your time.
Assalamu alaikum. Thank you, Dr. Mustafa. Now we are going to the last topic. Last topic will be about the CB of post-COVID-19 pneumonia lung fibrosis. It will be presented by Dr. Majid Azhar, the radiological resident in our department in King Abdullah Complex. R2, and the presentation is supervised by Dr. Rada Al-Turkistani, the cardiothoracic consultant in our institution.
Assalamu alaikum. Thank you, Dr. Ahmed. So today's presentation about CT post-COVID-19 pneumonia. We'll have a brief touch over SARS-CoV and various terms used. We'll get to know what PASC stands for, and we'll get to identify various CT abnormalities and common radiological appearances seen post-COVID on further follow-up. And we'll get to know the etiology and parameters for anticipating the fibrotic-like changes post-COVID-19 infection. So we know that COVID-19, which is a disease caused by SARS-CoV or severe acute respiratory syndrome, and PASC refers to post-acute sequelae of COVID, which is persistent symptoms of or long-term constellation of symptoms most commonly reported were loss of taste and smell, shortness of breath, and fatigue. So we know that the incubation period is around 4 to 5 days, and symptoms ranges from completely being asymptomatic to severe pulmonary respiratory failure. More than 50% of COVID-19 survivors will definitely have an abnormality on CT. Most common reported abnormalities were ground glass opacities associated with subpleural bands. These findings were more common seen 3 months follow-up. Then on further 6 month follow-up, persistent ground glass opacity or associated with or without reticular changes and fibrotic-like changes were seen. Now, precise radiological description and the term fibrosis should be reserved for patients with real CT findings of fibrosis, such as traction bronchiectasis and honeycombing and reticulation. And the long-term outcome is still unknown. The impact on the lung itself is yet unknown, and future research is on. We say that the lung involvement is seen in the acute phase. At 3 months, we can see ground glass opacities with subpleural bands. At 6 months, either resolution of the ground glass opacity or development of signs of fibrosis. We have various coronal and axial CT images of the chest. Letter A image, which shows traction bronchiectasis, which is one of the signs of fibrosis. B shows subpleural bands. C shows multiple areas of honeycombing, also goes with fibrotic changes. Letter D and E shows adjacent pleural thickening, which is also a sign, one of the common findings reported in post-COVID follow-up. Now, ground glass opacity does not necessarily mean fibrosis, and we say that the recovery is variable. Patients might completely recover, and lung parenchyma will totally resolve, and some others will go on and develop fibrosis. The PASC, or the constellation of symptoms, as we say, was shortly named as long COVID, and they changed it, and now it is named as PASC. Various risk factors include increased age, body mass index, female, and a higher CT score initially at the time of presentation. Again, multiple axial CT images of the chest, which shows at the time of admission bilateral patchy areas of consolidation and reticular abnormality. And 2 months later, the patchy consolidation areas subsided, but the ground glass opacity is moderately increased. 7 months later, we see complete resolution of the parenchymal findings. On the other hand, some other people will develop signs of fibrosis. These are also axial selected CT images of the chest, which shows at 6 weeks after COVID-19 infection, bilateral reticulations, and on further follow-up, we see interval progression and more prominent traction bronchiectasis in keeping with fibrosis. Other images, same findings, initially showed bilateral diffused mild ground glass opacities, the reticulations increased on further follow-up, and letter C shows extensive architectural distortion, which is also one of the signs of end-stage fibrosis. Again, at 2 weeks, bilateral extensive reticulation got more worsened at further follow-up with more prominent traction bronchiectasis. Now, the etiology behind these parenchymal findings is not yet known. These lung findings could be related to the prolonged need of mechanical ventilation or acute respiratory distress syndrome, or from the virus itself. However, some parameters or predictors for anticipating fibrotic-like changes were reported, most commonly the age being more than 50 and the need for non-invasive mechanical ventilation. Those were the references, various articles in the PubMed. I'll be happy to answer any questions. Thank you very much.
Thank you, Dr. Maggie. This is the last topic for our today, and I would like to thank you everybody who attended this day or this activity today, either in the house, in our hostel, or along the Zoom. So thank you all. And before leaving, I would like to thanks Ms. Saja Farzan. Ms. Saja is she's our hero here in the department, and she's behind all of this activity. أشكركم جميعا. كمان أشكر دكتورة غادة التركستاني اللي هي مدير إدارة الأشعة في صحة جدة على يعني السبورت اللي بتقدمه للمستشفى وبتقدمه للأطباء بالنسبة لنا احنا في القسم. وشكرا دكتور صادق شرفنا النهارده. دكتور صادق جستمية، شكرا جزيلا على حضور حضرتك. وان شاء الله اتمنى ان يكون التوبكس والاكتيفيتي الناس استفادت منها، وان شاء الله تتكرر بعد كده. واشكركم جميعا والسلام عليكم.
Yes. How was it?
And like this, yeah. Can you put your name? Your name.
Here?
Yeah, the first slide. Yes. The first slide. Yes, first slide. This is from the. Yes, yes, yes. Perfect.
Okay.
She's the Mustafa.
Hmm?
A big smile.
I'm not very good with pictures.
Last one, last one.
Oh, last one.
Last one, just
Stand here. You should.
I think you do. You like you do like really? Okay, have a seat. Why?
I have never been in a photo person, so
Yeah.
that's why.
Just like this.
يوم ممتع وجميل. شكرا لكم.
Did I get the smile?